Afternoon, everyone, and thank you, Jeremy, for that introduction. So now that you have seen that I am truly here, you're not speaking to a ghost, I'm gonna get rid of this camera. So this afternoon, I'm gonna take you through to intestinal helminths. In fact, we are going to journey together in a discovery of these worms. Just a disclaimer that I am, even though I'm a pediatrician, considering Jeremy's intro, I'm definitely not an expert, and I haven't had any extensive experience with helminths. And that could be because, you know, I've largely practiced in urban areas. Okay, the slide is a bit stuck. Okay, here's my next slide. Okay, so just for my benefit and anyone else that just wants an orientation into where the helminths belong, you know, when we talk about helminths, we're definitely in the field of parasitology. And looking at human parasites, you've got these big groups. The one group is the protozoa, which we are not even going to touch on today. We are going to be talking about the helminths, which is essentially worms. And amongst the worms, there are nematodes, which are the roundworms, and the platyhelminths, which are the flatworms. And the trematodes, which are the flukes, we're not going to touch on because they are not intestinal. We are going to be talking about the cestodes, and in that group, we'll touch on Ertinia, which is an intestinal helminth, and then we're going to go through the nematodes that are listed there, which are also intestinal helminths. So the word helminth is a Greek word that is really designed for me to bite my tongue, but it's just a Greek word that means worm. The worms themselves are usually macroscopic. However, the eggs require a microscope to be able to visualize them. So usually there is no host immune response to the living worms themselves. However, the dead worms or the larvae do initiate or stimulate an immune response. And in this situation, you've got varying degrees of eosinophilia. So going on to the intestinal nematodes, which are the roundworms, they are considered to be intestinal worms because the mature adults are found in the human gastrointestinal tract. However, the larvae, depending on the various nematodes that we are going to be discussing, are variously distributed throughout the body. There are mainly three modes of transmission. So the first mode is through ingestion of the eggs, either from contaminated hands or contaminated vegetable matter. Or the nematodes that are transmitted in this manner is the Ascaris lumbricoides, Tricurious Tricuria, and then the Enterobius vermicularis. Another group is transmitted via penetration through intact skin. And this is for the hookworms, which is Nicata americanus and Encyclostoma duodenale. And the other one is Strongyloides stechoralis. Then for those that like their pork a bit rare, so be careful of this one. So this particular one is transmitted via ingestion of the encysted larvae in muscle, specifically pork meat predominantly, and that's Trichinella. So if we look at the first one, I've deliberately kept this talk perhaps oversimplified so that we can get that general sense. And then if you've got that overview, then, you know, in certain instances, you may be able to dig in for more nuanced specifics. So if we look at Ascaris lumbricoides, we've got the life cycle on the diagram there. And we're gonna start off at 1. So 1 and 2. So those are the eggs that would be passed in feces. And that picture there is very deliberate, showing the soil and the environment there. So the unfertilized eggs wouldn't go any further development, whereas the fertilized eggs then develop in the soil. And they require specific soil conditions like moist soil, warm soil in shaded areas. So geographical areas that have got these soil conditions, then Ascaris lumbricoides, as well as other geohelminths, would then be endemic in those areas. And South Africa is one of them. So the eggs then develop in the soil, and you can see them developing there. You can see the embryonated egg at number 3, and then that is the infective stage where a human ingests the embryonated eggs via contaminated water, contaminated vegetable material. Once the eggs are ingested, they then land up in the small intestine where the larvae hatch, and then they penetrate the wall of the gastrointestinal tract, and via the circulation, they then end up in the lungs. And then from the lungs, they mature further, and in the lungs, they can then be coughed up, which is number 7 there, and swallowed, then re-entering the gastrointestinal tract. Then the larvae would then develop into mature adult worms, which then would mate, and then they would release the eggs, starting the cycle once again in the feces. So sanitation is very key, and safe water is very key to interrupt the transmission of Ascaris lumbricoides. So the clinical manifestations are largely it's mild infections and asymptomatic. However, with heavy infections, you can get abdominal cramps, and the worms themselves can invade the bile ducts, gallbladder, appendix, and liver, where they can cause various symptoms and signs due to mechanical obstruction. Kids are predominantly prone to these heavy infections, and in this setting, the kids can have malnutrition and even bowel obstruction. Many decades ago, this is the one experience that I have actually had of a patient that had a laparotomy for bowel obstruction, and it turned out to be caused by Ascaris lumbricoides. And this is not the actual patient, obviously, but that particular patient, I will forever have that picture stuck in my mind because it exactly looked like this. That's how huge the infestation was. And in fact, it looked really like spaghetti bolognese. And for decades, and I continue not to go anywhere near spaghetti bolognese. In fact, that one was even more so because it was a bit bloody. So this definitely occurs, and I have seen it. It was a patient that was presented by the ped surgeons at the combined pediatrics and ped surgical meeting at Charlotte, like when I was a reg. So if you think back to that life cycle, that the larvae would then migrate to the circulation and go into the lungs. And while they are in the lungs, then various symptoms and signs can then present. The patient can present with a cough, which may be associated with a wheeze. And obviously this can be confused with conditions like asthma. The patient on chest X-ray would have pulmonary infiltrates, and then they would also have a high eosinophil count on the diff count, and they can have these eosinophils on sputum MCNS as well. The diagnosis is through the visualization of the eggs in stool specimens, and on the FBC and diff and smear, if a high eosinophil count would alert you to this condition. And then these coughed up larvae can actually be also found in the sputum. So I have actually, I mean, patients love bringing you specimens of what they are coughing up, and I've actually never seen this. And I wonder if anyone in the audience has been presented with this particular specimen. So moving on to the next one. So these are the hookworms, and they have a different mode of transmission, in the sense that the filariform larvae have got the ability to penetrate intact skin. So if we start with an infected host passing the stool, then this stool will then develop also in the environment into these larvae. And the larvae would develop further in the environment into the filariform larvae, which have the ability to penetrate intact skin. Generally, it would be people or kids or even adults walking barefoot, and they penetrate in between the toe webs there. So a similar geographic distribution to Ascaris as well, also another geohelminth. So once it has penetrated the skin via the circulation, it would then land up in the lungs, coughed up once again into the GIT tract, and then the adult worms would attach themselves by these hooks into the small intestine and produce eggs once again, and as well as sucking blood. So the clinical manifestations, at the site of penetration, you would get an intense itch and rash. The pulmonary phase would be similar to that of Ascaris. And then the GIT symptoms are non-specific diarrhea, loss of weight, but also then because of what I've mentioned about it sucking the blood and attaching into the intestinal wall, you get iron deficiency anemia with hookworms. Diagnosis is via the demonstration of the eggs in stool, and that is just one sample there that is a wet prep. And then these patients can also have eosinophilia. Okay, so now we're going to move on to strongyloides, which is also called the threadworm. And its life cycle is similar, but slight differences. So if we start off with the infected host passing larvae in the stool. So in this situation, the infected host doesn't actually pass eggs in the stool. It actually passes just these larvae, which can then, in the same patient, result in auto-infection. So the larvae would then penetrate into the intestinal lumen and go into the pulmonary cycle. The larvae, once they've been excreted into in the stool and land up in the environment, would then develop into these filariform larvae, which is the infective stage, or they can develop further into the adult and male worms, who then have the eggs, which become the rhabditiform larvae, and then this cycle can actually continue cycling outside of the host. So this particular organism, as I've just demonstrated, is capable of completing its life cycle entirely within the human host. And as a result of that, chronic asymptomatic infection is sustained for decades. And clinical manifestations can occur long after the initial infection. And if you look at those patients that have got a chronic infection and they've got subclinical infection, when they subsequently become immunocompromised, you can get excessive larval production by this auto-infection cycle, and this can lead to disseminated disease. So when you have the acute infection, There is irritation at the site of entry, similar to hookworms. You can also get a mild non-specific GIT symptoms during the GIT phase. The pulmonary manifestations are the same as previously described. However, with this infection during the auto-infection phase, you get a pathognomonic rash called larva currents. And this currents just means a running larvae. And this is really a migratory rash showing the larvae as they make their way into the circulation and into the lungs. So the patients that have a chronic infection can really present a diagnostic challenge if they are symptomatic. They can get GIT bleeding, chronic malabsorption, ascites. They can even get arthritis and nephrotic syndrome. And then those that are immunocompromised can then get severe infection. And the risk factors for getting the severe infection are patients that have got deficiencies in their cell-mediated immune system. So if we look at infections that cause that, it's HTLV1 and HIV. And I mean, these HTLV1 and HIV are actually quite huge burden of these infections. However, it's really not such a common condition within these infections, but it can definitely occur. And I think in the pediatric setting, I have never seen a patient who has got strongyloides, but perhaps we are missing it, as I'll come to later on. Other risk factors, and the most common one is iatrogenic conditions where the patient is on chronic steroids for various conditions for which they can be on chronic steroids. Transplant patients, both donor and recipient, and of course the immunosuppressants that they receive, the post-transplant phase. Alcoholism and malnutrition as being also immunodeficient states, and primary immunodeficiency disorders. So when they've got hyperinfection, so what happens is that you get accelerated autoinfection, and the signs and symptoms are really much more severe infection signs and symptoms. But this is from the increased larval migration in the organs that are normally involved in the autoinfection cycle. So GIT tract, the lungs, and the skin. However, when the infection disseminates, so you get a hyperinfection syndrome that spreads then to organs and tissues outside of the autoinfection cycle. And this can be any organ like kidneys, mesenteric lymph nodes, the heart, and even the brain. And in this setting, this infection can look like sepsis, can look like meningococcal infection, or even septicemia. And patients can present with ARDS and multi-organ failure. And strangely enough, in this setting, the eosinophilia is usually absent. And in the hypothesis is that it could be as a result of the immunodeficient state. So the diagnosis, we said there are no eggs that get passed in the stool, so you would find larvae in the feces. There's a test called the Entero test. I've never administered this test. Perhaps some in the audience have done it. But the patient is made to swallow a string of nylon, and then this string is then later on pulled out via the mouth, and then the larvae would be attached to this string. So in that pulmonary phase, the patient could be coughing up sputum that on MCNS would be able to identify the larvae and the eosinophils. And in the blood, there can be eosinophilia. There's also an ELISA and PCR test that can be done to diagnose this condition. So the ELISA is much more sensitive than the microscopic, like the other tests that we've already mentioned. And I'm not sure in our setting whether the PCR is available. So endoscopy is not a test that would be routinely done to try and diagnose strongyloides. However, in that setting of chronic infection where the patient is presenting with non-specific chronic GIT symptoms, then the patient could have an endoscopy that ends up landing with the diagnosis. So those are the larvae there, and I think there's probably an iodine stain on that. So unlike the other helminths that we've discussed thus far, the drug of choice for the treatment of strongyloides is ivermectin. You can also use albendazole. However, ivermectin has got a better efficacy compared to albendazole. So our next intestinal worm is Trichinella. And the life cycle of this one here, if we start off with, so there's two cycles. So you can get the cycle that is in the wild and then the cycle that is in the domestic animals. And we'll focus on the domestic animals, but essentially the cycle in the wild, sylvatic cycle, is exactly the same. So predators in the wild, or even the pig actually eating just everything, can then ingest these encysted larvae in the muscle of whatever other animal that they're eating. And so then these cysts would then be in the animals, and then the human would then ingest undercooked meat, whether they are eating game meat or pork. So once in the GIT, then the larvae are released, then they penetrate the small, they develop into the adults in the small intestine, and the adults would then be releasing these larvae, which then penetrate the mucosa of the GIT tract, and then they land up in the muscle. So in the muscle, they can actually be there for years and years and years. So the symptoms are largely asymptomatic. You can get non-specific GIT symptoms. And when the worms penetrate the intestinal mucosa, you can get a fever during that time. And then once the larvae are in the muscle, you can then get fever and myalgia. And there's a severe form of the presentation where the larvae are in the myocardium and in the brain tissue. And so with myocarditis, encephalitis, and this can even be fatal. The diagnosis is via specific serology. You can also do a muscle biopsy, and there's just a slide showing with a muscle biopsy and eosinophilia, and you can have elevated muscle enzymes. So the prevention and treatment is essentially to kill the cysts. So either you freeze the pork and you make sure that it is cooked well prior to ingestion. As far as treatment, the mild disease is treated symptomatically, and the severe disease is treated with albendazole plus steroids. However, the albendazole is not effective against the larvae, rather targets the intestinal worm, and mainly the steroids are what are targeting the inflammatory response. So the moral of the story is that, you know, don't be a wolf, and rather make sure that your pork is well cooked. So this particular worm, Tricurious Tricuria, its claim to fame is that it is just about the only thing I remember from my parasitology lectures in medical school, just the tea tray, which is the shape of the egg, and that is Tricurious Tricuria, and I didn't remember anything else after that. The Tricurious Tricuria is also called the whipworm, and that's just because of the shape of the worm. So this very thin part is normally embedded in the intestinal wall, and then this is this part that looks like the handle of the whip, with then stick out. The life cycle, this particular worm has got a very simple life cycle, and it doesn't have the phase that goes through the lungs, and as such, you don't expect any of those symptoms. So if we start off with an infected host who would then be passing the eggs in feces, and then in the environment, these then develop further until you get the embryonated eggs, which are then ingested by humans, and then it begins the whole cycle once again. So infections can be asymptomatic, and if you've got a very heavy infection, moderate or heavy infections, then you can have a non-specific abdominal symptoms. So some of them that are unusual is nocturnal stooling, and this kind of infection predominantly affects kids. So perhaps if a child presents with these kind of symptoms, you might suspect it. Patients can have colitis and dysentery, and this then leads to anemia. And even though the infection is usually in the adult worms are in the cecum, so with very large infections, the worms can also be in the rectum and the descending colon, and in that situation, they then cause a rectal prolapse. So with this degree of inflammation in those settings, you can have some eosinophilia. And this was a bit of an eye-opener for me, that I didn't know that you can get clubbing with parasitic infections, so the whipworm in particular. And I suppose the pica is from the anemia that they get. These patients have been shown to get growth retardation and impaired cognition. However, you know, it's difficult to tease out what the effect of just purely the whipworm is versus comorbidities in countries where this infection is endemic, and as well as other social determinants of health in the situation where you've got endemic whipworm infections. So the treatment for a whipworm is albendazole, mebendazole, so end it. So this next worm, the pinworm, so this particular worm actually is very widely distributed, both in temperate parts of the world and tropical and subtropical parts. And it is the one infection that occurs in all socioeconomic groups. It's mainly children that are affected predominantly, and that's just because of the higher risk with kids with regards to hand hygiene. It's got a very interesting transmission. So, additional aspects to the transmission that I found to be interesting. So if we look at the life cycle, another very simple life cycle, similar to the pinworm. So if we start off with an infected host passing the eggs. So these eggs, so what happens is that these eggs pass out, and then in the perianal folds, then they mature within 4 to 6 hours. So not really requiring any other environment, just in the perianal folds, the eggs would mature within 4 to 6 hours. So because of this intense itch that the patient can have, The patient would then be scratching, and then the patient would then auto-infect themselves through the microscopic microscopic eggs that are now on their hands, embedded on fingernails and that. And as well as, so the patient can auto-infect themselves, but because the hands are now contaminated, so that infected patient would then cause person-to-person spread as well, because their hands have got these eggs, as well as contaminating the environment that they are in. So all the high-touch surfaces would definitely be contaminated, as well as the bed linen. Now, this is what I found interesting, is that, you know, in the bed linen and other fomites, that these eggs can also get airborne, and then they can then be inhaled, and then this can be inhaled as well as swallowed. And this can be another mode of transmission. So now you have it that worms can also be airborne, as though we don't have enough, a huge burden of airborne infections that we have to deal with. So these eggs, by whatever route of transmission, can then be, sorry for the interruption, can then be swallowed. And once they are in the small intestine, the larva would hatch and then develop into the male and female adult worms, who would then mate in the cecum. And then the gravid female every night migrates to the perianal area and lays its eggs. And then the cycle begins once again. So mostly it's asymptomatic. However, the most problematic symptom with regards to this infection is this intense perianal itch. And this is considered actually pathognomonic for pinworm. I have to say, in my experience, you know, when patients have experienced this, we've actually just treated them without actually attempting to make the diagnosis. So the diagnosis, it can be made via direct visualization of the worms. And this is at night as they come out to lay their eggs. So they can be visualized directly. They are very tiny worms. And then a Scotch tape can be put onto the perianal area, which would then pick up the eggs. And then this would then be viewed under a microscope, and then you would be able to see the eggs. So this is the Scotch tape technique there, and this is the wet prep. And treatment is once again with either albendazole or mebendazole. And in addition to that, because the transmission is very much related to hygiene, hand hygiene, so avoid scratching and washing the sheets daily. So I found this very interesting poem that I think you might find it useful to remember in a very simple way how to treat these infections. So the poem goes, think of a worm, worms bend them a lot, and you can kill them. I thought this was very cute. So essentially, most of these intestinal nematodes can be treated with the albendazole, mebendazole, and thiabendazole. The last one is not used predominantly because of its side effects. So you've really got a choice between albendazole and mebendazole. There are other alternative agents like parental permorate, as well as ivermectin. So ivermectin is predominantly for strongyloides, would be the drug of choice, but you can also use albendazole. And this parental is effective against ascaris, hookworms, and the pinworms, enterobius. So there was one study that was done in Mali, looking at the efficacy, comparing efficacy of albendazole, mebendazole, and pyrentel. But this was specifically towards hookworms. And in this study, the best efficacy was with albendazole, which had an efficacy of between 92 and 99%. Mebendazole was somewhere between 60% and 90%. And with pyrentel, there was quite a huge range from 5% to 90%. So my take-home message is I'll start with albendazole with all of these worms, and then I can hone in closer to look at whether do I need to use ivermectin because it's a strongyloides, or some of them actually do require, rather than the stat dose, repeat doses. The mode of action for all of them is not completely understood, but predominantly it's thought to be by causing paralysis of the worm, which can then be passed in history. So when we look at prevention of the intestinal nematodes, there's various strategies, and one of them is mass deworming. So mass deworming of entire populations in areas where these nematodes are endemic is not really recommended. However, with kids, WHO recommends that children should have these repeated doses for mass deworming. Now, South Africa does adopt this strategy, and kids from 6 months of age up until 5 years, every 6 months, they get deworming as part of their extended program of immunization. The one thing that I found interesting, I didn't know that there was rather a controversy around this strategy. Now, huge studies have been done around this, looking at the efficacy of this mass deworming of children. Now, the concerns around worm infestations are the failure to thrive that I have mentioned, the cognitive effects, as well as the anemia, and the other severe manifestations, but predominantly the ones that I've mentioned thus far. So the one thing that has been proven across various studies that, you know, patients that benefit the most are the ones where you've proven that they are actually infected by these worms. So when you look at mass deworming of children, there was one study, I think in India, a huge study that seemed to show benefit, but other studies that actually contradicted that. And when they took the data and sort of reanalyzed it and looked at where the greatest benefit was, it was once again in the children that were actually infected already. Be that as it may, this continues to be a strategy in a lot of countries where these worm infestations are endemic. With pregnant women, so this is not an adopted strategy, but there are some countries that look at whether pregnant women should be getting mass immunization as well. But mainly, the main strategy that is adopted is that if a woman is pregnant, so you would predominantly wait for her to deliver before treating. And I wondered why this concentration on pregnant women with regards to worms. And it seems that the worm infestation kind of predisposes to us. There seems to be some kind of interaction with immune responses to malaria, whereby even in kids as well as pregnant women, it predisposes them to severe forms of malaria. So notification is for the geohelminths, and it's for Ascaris lumbricoids, Tricurious Tricuria, and the hookworm. And these are the worms that have got that environmental cycle. So these are, in South Africa, is a category 2 notifiable medical condition. And I've always wondered why is strongyloides not in this group, because it is just as significantly transmitted via the soil route as these other geohelminths. And so in looking at this, really the answer lies in the fact that I think, but somebody in the audience can perhaps enlighten us further, looking at the distribution of strongyloides. So the red areas, it's where it is hyperendemic. And if you look at South Africa, it's sporadic, it occurs sporadically in South Africa. Perhaps that would explain why I've never encountered a patient who's got strongyloides. Okay, so we're gonna move on to our flatworms, or the platyhelminths. And starting off, we said we're not touching on the nematodes, so we're looking at the tapeworms. So these are flat intestinal worms, and they don't have a true digestive tract, and they would then suck up digested nutrients from the host. They are hermaphrodites, so a single tapeworm can produce offspring. And the human is the usual host, and then the other animals are usually an intermediate host. We're gonna start off with Ertinia, and these Ertinia solium and Ertinia saginatum are the two predominant ones of the Ertinia. And looking at the life cycle, so if you've got the infected host, which is the human with the tapeworm that is in the intestines, so in the large intestine, the human would pass the proglottids and the eggs, and then these, in areas where there's poor sanitation, would land up in fields where grazing animals would then graze. So with cattle, you can get the Ertinia saginata, and then with pigs, it's Ertinia solium. So then these eggs would then, the oncospheres would hatch and penetrate the intestinal wall and get into the circulation and into the musculature of these grazing animals. So there they are in the musculature, and then humans, when they ingest raw or undercooked meat, infected meat, would then get infected and start the whole cycle once again. So in the human, the infection is, and this is the human as the host, is largely asymptomatic. The significant infection with Ertinia is cystic sarcosis. And this is when the human plays the role of the pig and becomes the intermediate host. And you can get these larvae that are now encysted in muscle and the brain. And predominantly when it's in the brain, you can get a neurocystic sarcosis, which can present with seizures, obstructive hydrocephalus, and focal neurological deficits. So this I have actually seen when I was a registrar again, but only once. And this was a patient that presented pretty much with a scan that looked like this. A patient that was originally from the Eastern Cape, then the relatives brought over because of the intractable seizures. The patient virtually was now presenting as though the patient had CP. And on the scan, this was the picture that we saw with this particular child. So the treatment for the tapeworms, the drug of choice is praziquantel, but you can also use albendazole. So the next worm, I'll just call it the fish tapeworm so that I don't bite my tongue, by Diphyllobothrium latum. Okay. So this is the fish tapeworm. And if you look at its life cycle, so it would begin with the human that is infected. If we start there with the human that's infected with the tapeworm, passing their eggs in feces. If these eggs then land up in water, so then these eggs would embryonate in the water, And then these coccidia that would hatch would then be ingested by something like a crab. And they would develop further in the crab, and then the fish that eat crabs would eat the infected crab, and then you would then have these larvae that are now in the next fish that ate the crab. And the predator fish that eat those fish would then be infected because of eating an infected fish. And if man then eats sushi, that's how man becomes infected. So this particular tapeworm is the longest human tapeworm, anything from 20 meters up to 45 meters. And because of this length, even though predominantly it is asymptomatic infection in men, it can result in some obstructive complications. The one important thing about the fish tapeworm is that it absorbs vitamin B12. And as a result, you can get a significant vitamin B12 deficiency and have megaloblastic anemia. So yeah, moral of the story, stay away from sushi. So our last intestinal helminth, which would be H. nana, or the dwarf tapeworm. As it says, it is the smallest tapeworm, and it enjoys a worldwide distribution, predominantly in children. It's a life cycle, so also a rather simple life cycle, where you've got the infected host that passes these embryonated eggs in their feces. These eggs can then further infect humans through ingestion of contaminated food or water or from their hands. And it can also be ingested by insects. And so humans become infected once again when they actually accidentally ingest these insects, perhaps in grain, and then they would end up being infected that way. So once the eggs land up in the GIT tract, the oncospheres would hatch and develop into these cysticercoid forms, which would then develop into the adult worms, with the scolex they attaching onto the intestines, and then the whole cycle begins once again. So in the human, the infections are largely asymptomatic. However, with heavy infections where there's like really lots and lots of worms in the host, you can get abdominal cramps, diarrhea, a lot of them really non-specific symptoms, loss of weight, loss of appetite, and interestingly enough, you can also get a pruritus ani with this infection. You can also get anemia, and in a very small percentage of infections, you can get eosinophilia. And the treatment is praziquantel. So we've got a poll, and in our poll, you must choose the correct match. Over to you, Jeremy.
This may be difficult to do by poll, actually, because the way you wanting.
So they must just choose A, B, or C.
Oh, okay. For a scenario you're going to give.
So which
okay.
two of those pictures actually match?
Okay. Sorry, I beg your pardon. Let me launch that.
Yeah.
Okay.
So if I can just make sure that people understand it. Does this egg go with this picture? And does this egg go with that picture? And does this worm go with that egg? So which of those match? So A, B, or C?
Cool. We'll give people another 5 seconds.
complicated instructions, these.
Cool. All right. Ending the poll and sharing the results.
Okay. So predominantly people were correct in choosing A, and this was quite simple because the clue is in my favorite worm, which is the tea tray, and that's the whipworm, Tricurious Tricuria. And then this is the egg of Ascaris lumbricoides, and then that is obviously a tapeworm. On this side, this is Ascaris, and this is a wet mount of a pinworm, Enterobius vermicularis egg. So I think that maybe the last one is a little bit difficult because it can be hard to say what egg is that. I haven't given you a scale for it, but I mean, that is clearly Ascaris lumbricoides. Well done, everyone. So thank you very much for your attention, and I welcome any questions, comments, or concerns. And I know that in the audience, we've got people that have got quite a lot of experience with intestinal helminths, and I'm ready to have you share your experience with us. Thank you.
Great, thank you so much, Nosisa. That's a really nice overview of a lot of complicated worms. I'm very sad you've gone off spaghetti bolognese. Hopefully, hopefully with adequate cognitive behavioral therapy, we'll get you back.
And sushi.
Yes. So apologies. Hopefully that fades with time. There are a couple of questions which have come in, some privately sent to me, some on the chat there. So just wanted to ask a few things. So one is, and maybe this is a question for John, because I know you did mention it in your talk, Lucille, but about the PCR test, where are we with that? Is this now routine in the first world setting to do it by PCR, or are we, and is this likely to be the way things go? Or is there still going to be a place for microscopy over the sort of, let's say in 20 years time?
Thanks, Jeremy. Yes, I think there'll always be a place for microscopy for various reasons. This was specifically around any particular helminth? Sorry.
Yeah, so sorry, for sort of the intestinal helminths, I mean, is PCR becoming a very common way of diagnosing it in a first world setting these days? Or, I mean, I know they don't obviously see many of them in a first world setting, but I mean, what's in a lab which may not see a case a year, presumably the microscopy skills are quite limited. I mean, is PCR a valid way to do this now?
Well, I guess it's being applied more and more. I suppose it depends who you're talking to. From our point of view, we believe that microscopy is still should be the standard for various reasons. Cost and convenience and speed, but as you know, especially for microscopic organisms, PCR, and including the protozoa, which we wasn't a subject here, PCR is probably more sensitive, specific, and things are going that way, yes. But I think helminths are somewhat different. I hope the microscopy isn't entirely replaced by PCR eventually.
Yes, no, we hope, and certainly no time soon. I mean, I don't. Yeah, it's just interested to see which way it goes. But as you say, they are different to a lot of the other intestinal organisms which are microscopic, where the PCRs does have an advantage in terms of sensitivity. I mean, I guess, and maybe one other thing before we get back to Nosisa, John, and Nosisa, please chip in if or anyone else as well. I mean, just almost sort of semi-philosophically, why on earth do these things have such difficult life cycles? I mean, there's so many organisms which, I mean, like, for example, what's in it in the worm to get out to the environment and then try and find an intermediate host only to get all the way back, when, you could be like Strongyloides and just have your own life cycle within one organism. I mean, I say that, because it doesn't seem to make a huge amount of evolutionary sense, but on the other hand, they're incredibly successful organisms. I mean, these are, these intestinal helminths are more than 1.5 billion people at least. So, whatever I think, I mean, clearly that's not true. I mean, they work incredibly well getting out into the environment and often trying to find an intermediate host depending on the species, but certainly trying to cope with the environment before getting back. I mean, is there any kind of philosophical broad reason behind that, or are we still a bit in the dark as to why these organisms chose such a sort of left field way, to use an American metaphor?
Well, my sense, Jeremy, certainly with regards to the geohelminths, is that if they were using, if we just stick to auto-infection, that is just one host. Whereas, get out into the environment and you've got the billions of people. That would be my philosophical take on it.
Yeah, and I guess maybe it's just costly to reinfect one host when you could, as you say, not evolve that part of your life cycle and just concentrate on spreading to everyone else. So I think that's a good point.
Yes, I think philosophically, I mean, you're just looking at the wonder of evolution and what it can produce. I don't think it's any more complicated than that, really. And of course, organisms have co-evolved, and so as part of the co-evolution and the arms race, but between hosts and pathogens, these various strategies have evolved, but they've only evolved because they provide an advantage to the to the organism.
Sure. Agreed. And as you said, the proof's in the numbers. I mean, they are one of the most successful human, I suppose we call them pathogens, around. They really are. There's not a lot of diseases which affect 1.5 billion people, or cluster of diseases even. So that's incredible. As you say, it's a remarkably successsul strategy.
Well, and throughout biology, actually, parasitism is rife. Doesn't matter which kingdom of organisms you look at, everything is parasitized by something.
Yeah. Yeah. It's always something, there's some life lesson in there for sure. It was a question in the chat, which is an interesting one, about the use of helminths for some medical conditions, so inflammatory conditions like inflammatory bowel disease or celiac disease or allergic conditions, given the theoretical potential for sort of immunomodulation. I don't know if you came across that at all, Nosisa, in your reading, or else, John?
No, I didn't, and I didn't even fully understand the question. So, no, I didn't come across it. I'm not aware of. I mean, my sense of it with the immune modulation is that it's not beneficial to the host, but the question seems to suggest that in a beneficial manner. So maybe the person who asked the question can enlighten us. But anybody else can also have a go at the question.
Yeah, so the theory behind it, I think, is that you get a Th2 response from these organisms, which can modulate the immune system in a way, in theory, which might be beneficial. So you might get down regulation of the sort of processes which lead to inflammatory bowel disease and celiac disease and some allergic conditions. And there's kind of there's a theoretical basis for it, and there's kind of some weak level evidence for modulation. I mean, I know a couple of years back, Cochrane did a review of it for inflammatory bowel disease and found no good evidence for it. My sort of reading of the literature, and I haven't looked at it recently, but is that there's still no good evidence for any of those conditions really being clinically meaningfully cured by helminth infestation. Because of course, you would give yourself or give the patient these over. I mean, people have tried, and unfortunately it tends to attract a lot of cranks as well, kind of on the fringes of medicine, but doesn't mean that it doesn't work, just means that it does get tainted a little bit with that on occasion. I don't know, anyone else want to chip in on that point, or John, or anybody else?
Yes, well, the same sort of theory has been argued as to whether it may presence of helminth infections may interfere with immunization, for example, or may in fact assist it. Response to vaccines, and that's been floated as one of the reasons why maybe COVID-19, there's such variation in response to COVID-19 or to the infection. But just to Nosisa, just to correct something Nosisa said right at the beginning, and that is that there's no immune response to adult helminths. Well, that's not correct. You can get intense immune responses to adult helminths, to the extent that some people may be able to eliminate the infection from the gut, whereas others may not, and that's one of the reasons why you tend to get an uneven distribution of infestation or infection in a community, with a small group of children often they're looked at that have high levels of infection, and the vast majority have much lower or even none.
Yeah, it's just fascinating, and as you said, incredibly intricate interplay with biology between the host and the helminth there. So fantastic. Thank you very much, Nosisa. I think we need to move on just for time reasons, but that's a really nice overview, and thanks for covering so much in such a nice, clear way. Really, I think a lovely level of detail for us as well on a Monday afternoon. So pretty much the sweet spot. So thank you very much.